By the time he was 2 years old, this patient had survived more surgical trauma than most people endure in a lifetime. Born with complex congenital heart disease, he navigated multiple open-heart surgeries, culminating in a definitive Rustelli procedure that completely rebuilt his cardiac anatomy. His physical recovery was textbook. The artificial conduits were patent, the structural rerouting held perfectly, and the plumbing of his heart was entirely sound. Yet 7 months later, his heart began to quietly and rapidly fail. Survival now depended on a factor entirely separate from the surgical repair: the presence of an invisible, essential micronutrient. Because of severe refractory gastrointestinal allergies diagnosed in infancy, this patient survived entirely on an elemental diet. These synthetic, pre-digested formulas provide necessary macronutrients without triggering an immune response in the gut. During a routine follow-up, echocardiograms revealed a massively dilated left ventricle. Blood tests confirmed the crisis. His B-type natriuretic peptide, a primary biomarker for severe ventricular wall stress, had spiked to alarming levels. The clinical presentation was contradictory. The child remained largely asymptomatic, his electrocardiogram showed no ischemic blockage, and his troponin levels, the standard marker for heart muscle death, were completely negative. The heart was rapidly expanding and losing its ability to pump, yet showed zero evidence of trauma, viral infection, or coronary disease. Something was destroying the muscle from the inside out. The medical team initiated a process of systematic exclusion. Imaging quickly ruled out a mechanical breakdown of the surgical conduits, and the clean ECG combined with negative troponin eliminated a blockage in the coronary arteries. With structural and ischemic causes off the table, the investigation pivoted to the patient's nutritional history. Synthetic elemental diets lack the complex proteins of natural foods, meaning essential trace elements are missing and less specifically and continuously added by a compounding pharmacy. A specialized blood panel revealed that the patient's serum selenium levels were below the limit of laboratory detection. The tissue was starving at the biochemical level, deprived of the raw materials required for cellular survival. To map the exact nature of the cellular starvation, clinicians utilized dual-isotope myocardial scintigraphy, a specialized imaging technique that separates blood flow from cellular metabolism. This diagram represents the scan. On the left, the tracer smoothly highlights microvascular blood flow, confirming oxygen delivery. The right side maps fatty acid absorption. Despite steady flow, this map remains entirely dark, revealing tissue failing to utilize any energy. This spatial discrepancy is a severe perfusion metabolism mismatch. The cardiovascular plumbing is delivering the fuel, but the mitochondria inside the cells are paralyzed, unable to burn a single drop. To understand this shutdown, we look at mitochondrial protection. A healthy mitochondrion uses selenoproteins to build a protective shield, neutralizing dangerous oxygen radicals. Without dietary selenium, this shield vanishes. Toxic reactive oxygen species multiply unchecked, attacking the mitochondrion until its walls violently crack and swell. This membrane damage triggers ferroptosis, an iron-dependent form of programmed cell death driven by runaway lipid destruction within the cellular walls. Instead of violently bursting in a way that triggers a massive immune alarm, millions of cardiomyocytes quietly execute a programmed self-destruction. As individual cells delete themselves, the ventricular wall steadily thins and dilates. Because the death is highly regulated rather than acute, standard trauma markers like troponin remain negative, masking the severity of the heart's collapse. Reversing a deficit this severe requires intensive intervention. The clinical team deployed aggressive pharmacological selenium infusions to rapidly force the element back into the depleted intracellular stores. Rebuilding complex intracellular proteins takes months. During that enzymatic delay, the weakened heart muscle remains highly vulnerable to a fatal pump failure. To bridge this gap, clinicians introduced SGLT2 inhibitors like dapagliflozin. As this flowchart shows, the drug forces the heart to bypass its paralyzed fatty acid pathways and burn highly efficient ketones for immediate energy. By securing an alternative energy supply today, the heart is kept beating long enough for its molecular machinery to rebuild for tomorrow. The patient experienced a biphasic recovery. After navigating a precarious first year, the myocardium achieved complete structural and functional normalization by year 3, contracting with robust, healthy force. Serum selenium levels below 70 micrograms per liter in a heart failure patient correlate with a 50% increase in mortality. This threshold represents an immediate red flag that mandates protocolized screening, particularly for anyone relying on long-term synthetic nutrition. Treating a secondary metabolic cardiomyopathy requires looking beyond the structural plumbing of the chest. It demands a fusion of molecular imaging and nutritional science to identify the invisible drivers of disease.